Okay, guys, thank you for coming. Thank you for making this time. I'm going to start with chapter 8 on EGANs. If you want to go look at it, it's page 150. And I'll tell you what you need to know as far as highlighting. If you have the book with you, the next book with you, you can go ahead and start highlighting. If you don't have it, that's okay. I will tell you what I'm looking for, what you should be looking for. And then we'll go forward. So page 150, EGANs, 10th edition. What I'm looking for and what you need to know is this. What it says, first paragraph and second paragraph. First paragraph says external respiration. So those of you who don't have the book, you can go ahead and write it down, external respiration. You need to know the definition of that. Page 150, left column. Page 150, left column, the very first paragraph is bold, black, bold. It says external respiration. And it is the exchange between a gas in the atmosphere and the blood, which is inside of your lungs, which is inside of my lungs. So we're talking about external respiration. Even though it is inside of your body, inside the lungs, doesn't mean it's internal. It still is external. So we want to know external respiration. Please make sure you know this because this is extremely important. And the next thing you want to know is internal. External and internal. So internal, we're talking about blood and the tissue. So the first one talks about air and blood. That's what it is. And the second one talks about blood and cells. I will be using the word cells and tissue interchangeably. When I'm saying cell, it could be one. Tissue, multiple of cells would be tissue. So we'll keep going back and forth. You would know it also, because when we're talking about hypoxemia, we refer to the cells or we refer to the tissue, whichever comes first. And if it is not clear, please raise your hand and ask me before I go to the next topic or next sentence. I want you to understand before I go forward. And then at the bottom of that paragraph, it says the following. It says that gas exchange takes place, this whole gas exchange right here. This whole gas exchange takes place by simple diffusion. Simple diffusion means simply passing through the membrane. Just like a coffee maker you have in the morning when you make coffee for yourself. What is happening there? Well, hot water goes through the coffee grind and passes through the coffee filter. That coffee filter is AC membrane. So you can keep that in mind. And then we'll keep going forward. Go to page 151. What you want to know under that table, table A-1. And this is also good for those of you who are going to graduate pretty soon and graduate in a few months also, because you will be tested on UNAID as well. So you want to know the following, that our cardiopulmonary system goes through an event, a few events. Number one is embryonic period. You can look at it, table 1-1, under gestational age column, it says embryonic period. I'm not going to ask you to know the days and the weeks and the this or that. No, rather, you need to know what is the first stage, embryonic. What is the second stage is what we call fetal period. So be sure to know that part also. Fetal period also has been broken down to 3 different stages. You don't really need to know, but you just need to know what's going on, particularly under fetal period, alveolar stage. So alveolar stage is extremely important, and you guys know why. It's because of the gas exchange purposes. So alveolar is a functional unit of the lung that does the gas exchange. So we need to know that part. So be sure to know that. And then period after birth. Well, after birth, we have a lot of other development that we're going to talk. This is it so far when we're talking about cardiopulmonary system that is being developed and is going forward on and on and on. Is there any question up to this point? No. Okay, go to page 153 now. 153, what you need to know at this point, 153, right column. When you see it says acinus, please highlight right column. Black bold says acinus. Acinus, A-C-I-N-U-S. It says the basic gas exchange unit of the lungs. So you need to know that terminology. And then you want to know is what it says, two other bold type 2 pneumocytes and type 1 pneumocytes. So be sure to know that alveoli, alveolus is singular, plural would be alveoli. Alveolus is made up of type 1 pneumocytes. Be sure to know, how does it look like? Flat, like a flat paper. For gas exchange purpose, surface area is great. Type 2 is cubital. Cubital means that it looks like this, right here. That's what it looks like. And the reason behind it, because it's like a fountain and produces surfactant, just like you guys already know it. So that's the shape of it, type 2. And then we have type 3. What does type 3 do, Josh? Type 3 goes around, roam around, and then macrophages, kills, digests, engulfs the bacteria, the organism. Any material that goes into the alveoli, and it shouldn't be there. So that's what it does, it kills it. So be sure to know type 2 and type 1. Page 153, make sure you know the rule of thumb. So highlight it. Highlight the rule of thumb because you will get to know it. Under neonate, you will get questioned. And any other time, you just need to know it. Page 154, rule of thumb. And if you have not seen it, let me know. Rule of thumb says this. Right in the middle of the rule of thumb says, the period begins, we're talking about alveolar period, begins at about 32 weeks of gestation. So remember the 32 weeks because on the board you will see that says this neonate was born 28 weeks of gestation. What does that mean? Alveolar period has not been reached and we have problem with that. The problem is these pneumotype 1, 2, 3 are not going to work. They're not going to function well. Surfactant is the main one. Okay. Right at the bottom of the rule of thumb, underneath of it, it says pulmonary surfactant, which promotes lung inflation and protects the alveolar surface. So please take a note that pulmonary surfactant promotes lung inflation, keeps the lungs open, keeps the alveoli open, and also, look at what it says, protects the alveolar surface. So it does not get sticky together, and then every time you open up, what happens? Damages the alveolar structure. We don't allow that by having surfactant in there. Any questions so far? No, we're good. Okay, let's go 156. Page 156, under the headline says, transition from uterine to extrauterine life. This is the moment that a neonate is born from mom, comes out to this world. Now, what is taking place? First paragraph, make sure you highlight it and go ahead and read it and see what's going on with that part. As the baby has been pushed out of the canal, first of all, you need to know that lungs, neonate or fetal lungs are filled with fluid because there is no gas exchange taking place. As a result, it's filled up with fluid because it's receiving the nutrients and it's growing and it's growing and it's developing. However, this organ has been filled with fluid as soon as the baby is born, as soon as the neonate is born. Now it has to change and become air or gas filled. From being fluid filled to gas filled is a little transition, and the transition takes place being during the canal as the baby is being delivered and coming out of the mom. What is happening basically during the canal, because the bones are not really strong, has been pushed So 2/3 of that volume of the fluid comes out of the lungs. 2/3 comes out by being pushed through the canal. Another 1/3 will be done by recirculating the lymph nodes, and lymphatic circulation absorbs all the fluid, puts it into the cardiovascular system. This is what is taking place during the birth. So you need to know these parts to understand the physiology and anatomy of the baby as it's born. How much of a pressure it takes for the baby when it's born to open up the lungs. You guys already know that if the baby starts crying is a good sign, right? The reason behind it, if the baby cries, is it good? Because you need, or the baby needs to generate a pressure in order to open a structure. If I give you a balloon to open up, the very first time, is that easier? Or after 10 times inflating the balloon? After 10 times it's easier, just because you open the structure. First time is the hardest one because it's never been opened up, so it's the same. It takes 40 centimeters of a water pressure for the neonate to open that structure on the first breath. That's a lot of pressure. You guys right now, you guys are not going above 5 centimeters of a water pressure every time you're inhaling. Think of it, 8 times stronger a baby who is born, neonate we're talking about, their diaphragm is smaller, their muscles are smaller, they were just born, they have to open up the structure with such a force and exert such a pressure. So we're done with that part. 157, go to page 157. For those of you who are going to graduate pretty soon, be sure to know table 8-3. Every one of you eventually needs to know that. Those of you who are graduating, you need to know it today, or I should say you need to know it yesterday. So be sure to understand the pH, PCO2, and PaO2.
I'm sorry, which one?
Everything on that table. Everything on that table.
What table?
Table 8-3, page 157.
No, okay. I actually page.
Yeah, page 157, table 8-3. Ask me question as we are on that page, so I don't go too far away. Okay, page 157, right column at the last, under the heading it says fetal circulation. Be sure to know these shunts. We're going to talk about what is word shunt. Probably most of you already know because I ask this question all the time. What does the word shunt means? So what I'm looking for, the dictionary definition of a word is what? Is bypass, because I already asked you, right?
Yes.
Okay, so I already asked you, that's why. So the shunt means, the word shunt means bypass. So we want to understand the wording first, and then we're going to apply it. And you were absolutely right, Ashki. You're absolutely right. When we're talking about shunting in the cardiovascular section, we're going to go shunting about in alveolar section. We're going to shunt about any other stuff. What we are talking basically is bypassing. Bypassing the normal path is shunting. And then we're going to talk about what does it mean by shunting. Well, we have 3 shunts we need to know for the babies. Be sure to know it, at least know the names, and then once you get to the neonate section, you know it in more details and in more depth. Ductus venosus, it does take place in hepatic circulation or liver in babies. Ductus arteriosus, it takes place between a right ventricle and aorta. And then the last one is foramen ovale that connects the 2 atrium septum, right atrium to left atrium. Are we good with the heart section? We already know that heart, what's going on with the heart. We get to that part, I quickly go over the heart as well. So these are the shunts that we need to understand. And the reason we have those shunts because babies' cells, tissues are not able to handle such a high partial pressure of O2 that comes from mom. What's the partial pressure, PaO2, in a normal adult individual? 80 to 100 millimeters of mercury or torque. This is way high of a pressure for the baby cells. They cannot handle such a high pressure. As a result, this pressure needs to be dropped down and dropped down and dropped down. We cannot do it. We don't have escalator in the body, right? So what do? We use shunt. Shunt, we're bypassing. As a result, we are mixing. As a result, this partial pressure starts dropping and dropping and dropping. It becomes really, really, really low when it gets to the baby. And then this PaO2, when it reaches the baby, it becomes, what do you think? Charlotte, what do you think? What's going to be?
40.
Okay, you were right. Half of it, which would be right around 19 millimeters of mercury. So as you see, from 100 drop to 1/5 because the body of the baby cannot handle such a high partial pressure of O2. Page 159. Before we go to 159, let me tell you something about 158. Those of you who are going to graduate, be sure to know 158, figure 8-6, really, really well, because that tells you something about fetal hemoglobin versus adult hemoglobin. Fetal hemoglobin has more attraction, affinity, or we call it love sometimes, towards oxygen than adult. So by far, you need to understand this factor, and the reason behind it, because baby needs more oxygen, more nutrients, more activity for them to grow. As a result, they have more affinity. Their hemoglobin has more affinity, more attraction, more love for oxygen, for growth, because oxygen is actually some sort of a food for us. Oxygen is for combustion. Oxygen is good, but not really. And we're going to talk about it. Why not really? Yes?
How long does that last? I mean, how long into the baby's life does that last?
Oh, it's,
As far as, when a child comes more to the norm of the adult.
till the child becomes into age of 7 and 8.
Okay.
Till then, still the fetal circulation. When a baby is coming out, the neonate is born, this hemoglobin affinity starts slowing down. Completely gets to our affinity would be around the age of 7 and 8, because now the lungs are mature. If you look at the page you were looking at, it says, you go back to page 151, you will see that says, period after birth, 8 to 10 years old. Right around 8 to 10 years old, your lungs, my lungs are mature. At that moment, our hemoglobin is going to behave differently like an adult. Good question. Very good question. Any other question before we go to page 159? Yes, Josh.
On the table 8.3, it says the arterial PO2 for fetus is 19. Then on the venous, it goes up.
Correct.
Where did that oxygen?
That oxygen comes from mom, because vein and artery are going to be reversed at the umbilical cord. As a result,
Okay.
the number of blood you have, number of oxygen you have on either side is going to be different. There you go, just like Homer system. Very good. That's a very good observation. Excellent. Any other question? We're good. All right, let's go to page 159. Please be sure to know this picture really, 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 really well. Figure 8-7. Every single one of you need to know this, because it's a really good picture that tells you how the shunts are working, where are they located, and how are these taking place. By the way, the picture in front of you, the figure that you're looking at, it's the body of the neonate. It's a body of a fetus. It's not the mom. For the longest time, I was thinking that this is mom. It's not. I made that mistake. I want you to make sure not make that mistake. So when you're looking at page 159, figure 8-7, the picture you have and what you're looking at is actually a cardiovascular circulation of neonate, or I should say fetus inside the mom. Okay, let's go to page 161. We're going to go through this relatively quick. What you need to know is what are the things that are taking place. For example, page 161, figure 8-10, tells us about the upper airway of an adult and upper airway of neonate. Those of you who are going to take a board exam, you need to know this really, really well. Because look at the landmark, C345. C345 in adult versus neonate. When you're looking at, if you have to go through and look at it, you're going to see that there is a difference between the two. The difference between the two is adult is going to be a little higher. You have more space between the C3 and the nasal passages, because during intubation, you need to understand that factor. And also for neonate, you're going to see the difference, the height is a smaller. And of course, because the smaller stature. We are taller, they are smaller, is given, not really unless we pay attention to it. So that's the difference. Please be sure to understand that and know it. Take a note. Figure A-11, another factor that I have seen on board exam comes up and they ask the following. An object went to newborn's lungs. Which lung do you think this object will get dislodged? Right lungs, or right lung, I should say. And because of the angle we have in there, the angle is a pretty right angle. So most likely, if we are intubating someone, and if I go farther than what I should, what's going to happen, I'm going to go into the right lung, and I'm going to ventilate one lung, and I need to pull back. So these are the things you want to keep that in mind. These are the landmark. Be sure that you understand and you know it. Any questions so far? No. Okay, let's go to page 162. 162. What I want you to know and understand is right column, you're going to see a bold letters says phrenic nerves and intercostal nerves. Be sure to know phrenic nerves. What is phrenic nerves? I'm going to talk about it a little bit when we get to chapter 11. Phrenic nerve and intercostal nerves. These are very important. These are very, very important for you to understand where it comes, where it goes, so on and so forth. And then we're going to go into another factor as we go forward. Any question up to this point? No. Good. Page 165. Be sure to know the rule of thumb in that page. It is anatomical landmark. You need to know the anatomical landmark really well. If I don't test you, doesn't mean you don't have to know it, because they are going to describe a patient and you should be able to know it. And I will tell you, what am I talking about? I'm talking about anterior or anteriorly. What does that mean? Be sure that you know it. And if you don't know it, that's okay. Go home, look up the dictionary. Another word, posterior or posteriorly, because you will see a chest x-ray, it says AP diameter, anterior posterior, or posterior anterior. If I'm looking at Josh chest x-ray, AP, anterior posterior, it's going to look different. However, if I look at it posterior anterior, it will look different because organs will look up different on a chest x-ray. So we need to understand that part. And then another word, lateral. What does lateral mean? We're talking about either side. Bilateral means both sides. And then medial, right in the middle. So be sure to look at it when you get to that part. Please understand what's going on and all that. Any questions so far? No. Let's go. 166. Look at the page. Look at page 166. Be sure to understand figure 8-17. Common question on board exam will ask you about putting chest tube in someone's chest to remove hemothorax, to resolve pneumothorax, to cure pleural effusion, so on and so forth. You should be able to understand where to put it, how to put it to not damage certain area, organs, and systems. So if you look at figure 8-17 on page 166, you're going to look at two bones. So if we have two ribs, what you want to do is you want to look at where to put, if this is our chest tube or thoracentesis, I want to insert this where? And if you look at under any ribs, you never ever want to insert any thing at all whatsoever. Because there is a reason, there is a possibility that you damage vein, do you guys see it? Nerve or artery. So what is the safest place to put the thoracentesis? Above any ribs is safe. Below any ribs is absolutely no. This is a common question on board exam. I have seen it multiple times. So be sure that you know it as well. Right column, parietal pleural and visceral pleural. I always ask this question. Those of guys who are in the clinical, they know that I ask this question all the time because you need to just know it. Very simple for that reason. And parietal pleural, look at what it says. The inner layer of the thoracic wall, the inner layer, is lined with the serous membrane called parietal pleural. Parietal pleural, do you guys like baby back rib? Yes? Okay, because smiling, yes, I do. Delicious, right? Okay, the layer that you remove is what? That's it, thank you very much. That's what exactly it is. So if you cannot memorize all this, that's what it means. And then visceral pleural is the layer that covers the organs. In that case, we're talking about the lungs. It covers the lungs, so we're talking about visceral pleural. Between these two, there is a little fluid, pleural fluid, to minimize the friction. If we have too much in there, fluid, what do we call it? Pleural effusion. If we have too much fluid in there, as it shouldn't be there, then we call it pleural effusion. So what do we do in that case? We do thoracentesis, right? So be sure to know, those of you especially who are graduating pretty soon, you need to know how we do thoracentesis. How we do thoracentesis. Do I put it at my apex or I put it at the base? At the base, why? Because of a gravity, thank you. So just know it, because they do put simple questions, yet they want to know, can you think critically rather than just recall question? They're not gonna ask you, what is today, April 20th? No, they're gonna ask different way to see whether you're gonna get to that conclusion or not. So be sure about those parts also. You're gonna have the patient sitting this way, holding the chair, and then you're gonna tell the patient to go ahead, inhale. You're gonna get ready, put the thoracentesis, and then once the exhalation takes place, what's gonna happen to the structure of the thorax? Look at me. This is my thorax during inhalation. It got bigger. And then during exhalation, what happens to that structure? It gets smaller. So you're not gonna cause them pain. You're gonna let them inflate the structure, increase the volume, insert the thoracentesis, and then let them exhale. That's what's gonna happen. You're gonna push all the fluid out. You're gonna have all other mechanisms. But you just wanna know how to do it. In real life, you're not gonna do thoracentesis. You're not gonna chest tube. I know it, you know it, everyone's gonna tell you. But that doesn't mean you don't need to know it. MBRC does ask you. Because you're expert, they do ask you. MBRC thinks this. You're the physician, you're the pulmonologist, you're the nephrologist, you're the anesthesiologist, you're everything. For MBRC, you are everything and everything. As a result, you just need to know certain stuff. That's one of them. Any questions so far? No. Okay, let's go. We'll keep going. 167. Be sure that you know how many ribs we have. We have 12 ribs. The picture you have in page 167, the figure 8-18, is really, really helpful for you to understand the sternum and the parts of the sternum, because you need to understand the sternum when we do CPR during clinical, which you will face that all the time and you will get questions regarding that and all that. All right, any other questions so far? No. All right, let's go. Page 168. Page 168, under respiratory muscle, right column. Page 168, right column, respiratory muscle, under that heading. Line number 6, diaphragm and intercostal. Diaphragm and intercostal muscles are the primary muscles of ventilation. Please be sure to know this. Diaphragm and intercostal muscles. Two sets of muscles. internal and external. Be sure to know it and understand what they do, how they work, so on and so forth. This is how it works, and we just need to understand that and know it. Diaphragm also, if you look at under the same, go down about like 7, 8, beginning of the next paragraph, it says the diaphragm is a thin, musculotendinitis, dome-shaped structure. It's really, really a thin muscle. It's not really like your biceps or your leg muscle and all that. It's really a thin, like a sheet of paper. It's a mixture of a muscle and tendon. That's how it works. There's tons of picture online available also that you can take a look at it, so you would understand how it works, why it's there, so on and so forth. So that's diaphragm. Be sure to become familiar with diaphragm as we go forward. Any questions you have up to this point? No, none? Okay, let's go to page 170. Page 170, that little box, it says mini clinic. Highlighted, know it, because it talks about lung hyperinflation in emphysema. Lung hyperinflation in emphysema, or anything about hyperinflation, is this. When lung gets hyperinflated, AP diameter will increase because we have a structure in our body, and that structure is becoming engorged or enlarged. So when we're looking at, this is the structure of our lungs. Normally, that's what it looks like. However, when we are looking at our patient, we're looking at the chest x-ray, we did our patient assessment, physical examination, so on and so forth, we realize that this structure becomes hyperinflated. What does that mean? That means the volume has to expand over chronically a long period of time. As a result, you will see that all parts of the structure will move farther and away from what being normal. I also put the arrow for diaphragm as well. What does that mean? That means that diaphragm is getting pushed down. Is that a good thing? No, because diaphragm does how much of the work of ventilation? That again? 75% of the work of the ventilation is done by these diaphragms. Each diaphragm is called, okay, we have diaphragm, but it has two sides, right and the left. We call the right diaphragm right hemidiaphragm, and the left, we call it left hemidiaphragm. Please be sure to know it. Right hemidiaphragm is a little higher. Why? Because of the liver, thank you. The lobe of the liver pushes up. And then the left side is a little lower, and why? Because of the heart, the structure of the heart is there, it pushes down. So this one is a little lower, the left is a little lower, the right is a little higher as a result of that. We just need to know it. Also, another thing that we need to know, since we are on that topic, those of you guys who have not had patient assessment, you will see it. Those of you guys who had it, you will see this over and over and over. And we're talking about intercostal angle. A good intercostal angle is 30 to 45 degrees. And we're talking about this degree right here. This is a good degree. But if I push the diaphragms really, really low, due to hyperinflation, what do you think is going to happen to this angle now? It got blunted, that's what we call it, very good. And also we're saying that almost got 90 degrees. This is not good. This is good. You will see that when it says costophrenic angle, if it is sharp, it's good, 30 to 45 degrees. If it is blunted, it's not good. You will get this on board exam. They're not going to ask you what's the good intercostal angle. They will describe the patient's chest x-ray to you. You have to figure this out yourself. Just because you're the expert when it comes down to cardiopulmonary. So please be sure to study that mini-clinic really, really well. Okay, page 172. Page 172, figure 8-22. Study that figure and see what it says. It tells you external intercostal, internal intercostal. Those of you guys who are going for sputable, be sure to know it because someone will ask you there. Page 173, rule of thumb, to study it and know it really, really well. Page 175, mediastinum. 175, right column, right above the mini-clinic, mediastinum. Be sure to know what is mediastinum. Okay, the thorax, we have different organs in it. The major organs that we have that we need to know are two lungs, right and the left. In the middle portion, right here, they call it media, like medium, right? Sternum, which comes from a sternal, right? Mediastinum. Right in the middle, we have, what do we have in there? We have heart, that's one thing. We have a couple of other organs, glands and all that. You don't need to worry about that part. But you need to know the main one, which is the heart. So be sure to study mediastinum all the way to the top of the mini-clinic. And of course, mini-clinic is part of something you want to study and know. Board exam asks you about chest injury. What are you going to do for it? How are you going to treat it? Be sure to study it and know it. Any questions so far? Are we all comfortable? How many lobes we have on the right lung? 3 lobes we have on the right lung. And how many lobes we have on the left lung? 2. Okay, be sure to be comfortable with it. So you're not confused if someone is explaining it like, oh, I know it. Good. Excellent. All right, let's go to page 178. Page 178, figure 8-30. That picture is a really good picture for you to know blood circulation. I ask everyone about blood circulation. And I ask that, please take me on a trip with you. Take me on a trip with you from right atrium all the way through, and let's go through it and come back to it. You should be able to know it. If you want to challenge yourself, then go backward. Can you do that? And the reason you need to know that because of a hemodynamic, and you can ask Sean, who's here, and you can ask Benita, who graduated, you can ask her also. They get a lot of questions about hemodynamic all the time. You need to know the blood circulation really, really well. So become comfortable with it. If you're not, just start writing it down 10 times a day, 15 times a day, whatever it takes to know. Rule of thumb in that page, 178. Highlight the rule of thumb because rule of thumb tells you something really fun and interesting. You probably already know it, but it still is good to know. Page 179, table 8-6 tells you what you need to know forever and ever and ever until you become RRT. It tells you about the blood flow, which is cardiac output. It tells you also about arterial blood pressure, which you guys already know. What is a normal blood pressure? 120/80. This refers to left side of the heart. Explicitly, we're talking about left ventricle. 120/80 is left ventricle. What do you think it is on the right side? It's right there. 25/10. This talks about right side of the heart. Exactly, right ventricle. Right ventricle has to generate or does generate 25/10, where left side of the heart generates 120/80. This tells you something. Pressure always comes with another concept. What do you think it is? Pressure comes with another flow. Say that again?
Flow.
Yeah, one more.
Contractility.
Okay, this is normal pressure, normal
Friction.
friction, something else,
Viscosity.
something else, okay, something else. Say that
It's
again?
right here.
What'd you
It's
say?
right here.
Okay, go, what'd you say? Oh, we're getting violent now, we're getting violent, it's after 2 o'clock, that's why. That's why. Oh, thank you, resistant, thank you. Pressure always comes with resistance. So remember this part, please, that if you have higher pressure compared to the other one, what does that mean to you indirectly? More resistance you have. So you have higher pressure compared to the right side. This is the left side. This is right side. Higher pressure comes with higher resistance. Because the resistance is high, it requires a higher, because resistance is high, it requires a higher pressure to overcome that resistance. And because pressure is lesser on the right side, then we need to come up with lesser, because resistance is lower, we need to come up with lesser pressure to overcome that resistance. As a result, the left side of the heart is bulkier, more muscle, versus the right side. Any of us, if we start doing a lot of biceps, what do you think is going to happen to our biceps? It will get larger and larger and larger. And if we don't do any exercise, that large muscle will start going atrophy or getting smaller and smaller. So we'll go back and do more. What are we talking about? Resistance and pressure, pressure and resistance. And we're not done with this because work of breathing also, if the resistance of the airway goes up, what's going to happen to you guys? What do you need to do? We call it something, we call that work of breathing will increase. Well, what is work of breathing? What do you think work of breathing is?
Trying to get oxygen down.
Correct.
It's the,
It is pressure times,
or resistance, I'm sorry, volume.
if resistance go up, what do you need to do here?
Please go up.
This needs to go up. Who's going to help us to overcome the resistance? Pressure. So as a result, we call it work of breathing is increased. Work of breathing is increased is like this. This is not normal because my respiratory muscles are not able to maintain such a high work of breathing. As a result, I'm going to go respiratory fatigue, then respiratory failure, because work of breathing is high. What is your job as a respiratory care practitioner? What is your job every day? When you clock in and you go into work, what do you do all day long? Reduce work of breathing. Please keep that in mind because always all the question revolves around reduce work of breathing. Reduce work of breathing, reduce work of breathing. Asthmatic patient come to you, they're breathing really, really, really high, really fast. What do you want to do? You want to reduce that work of breathing. What do you do for them? You give them oxygen, you give them bronchodilator, you talk to them. If they're anxious, you give them Xanax or any other medication. What do you do at the end of the day? Your job is always and always going to revolve around reduce work of breathing. Because if the work of breathing is up, what's going to happen to the pH, you think? It's going to be out of normal. Our job is to bring it back to normal. That's what we're talking about. So please be sure to know blood pressure value because that tells you something else. Because that tells you if 120 over 80 is normal, 180 over 120 or 180 over 100 is not normal. That's what we're talking about. And also, look at the vascular resistance, third line on that figure, on that table. 1200 versus 120. That's what we're talking. So be sure that you know that section of it as well. Page 179, if you want to know something about bronchial circulation, you probably want to check that out because pulmonary circulation and systemic circulations are different. Our body has a cardiovascular system. Cardiovascular system has two sides, pulmonary circulation and systemic circulation. Everything else comes off of the systemic circulation. Bronchial circulation is one of them. Coronary circulation is another one, so on and so forth as we go forward. Okay, so this is what we're talking about, bronchial circulation. As we go forward, let's go another page. Page 183. Page 183. Right column. Fourth line. Another reflex that is associated with SAR and RAR activity is the head paradoxical reflex. This is something interesting, and if you like to read something interesting, you can read off of that. No one's going to ask you about this, but it's something like really fun to read and understand what the heck is going on. These are all the theory behind what is happening, so you want to know that. Page 184. Be sure that you're comfortable with that figure, 8-36. Also, what you want to know is box 8-1, particularly these three. Function of the upper airway. You will get a lot of questions, and it's good to know these because that gives you a good understanding behind what is happening. Filter, highlight. Heater, highlight. Humidification, highlight. Be sure to know, right column of the same page, at the end of the first paragraph, it says turbinates. Turbinates, we're talking about air moves violently. It's not a streamline. It's rather being turbulent. Yeah, being turbulent. So what are we talking about? It's bouncing back and forth against the nasal passages. We need it for filtration, humidification, and warming factor. That's what we're talking about. Okay. Any question up to this point? No? We're good? Okay, let's go another page. 186. Mini-clinic. Exercise-induced asthma. To study that. It's a good topic to know what we're talking about when it comes to mini-clinic part. What else we have? What else we have in there that is important for us to know? Figure 8-38. 8-38 is an important figure because uvula. Because what you're going to see in order to intubate someone. So you want to pay attention to that. Page 188, mini-clinic is snoring and a sleep apnea. Understand that a sleep apnea, in all of us, the main cause behind a sleep apnea is one large muscle. What do you think that is?
Tongue.
Tongue, thank you. Our tongue becomes really, really relaxed when we are asleep. As a result, that mini-clinic right there, you want to highlight it and you want to know it. You can become a sleep technologist, a specialist. Even if you don't want to, you need to answer board exam question regarding the sleep apnea. So one of the reasons behind the sleep apnea is the muscle, which is tongue, gets relaxed when you're asleep, falls back. What does it do? Obstruction of the airway. What is our job all day long? Airway management, right? What do we do with airway management? We make sure the airway stays open. That's what we do all day long. What we need to do is we need to make sure the sleep apnea does not take place. So just know that part also. On a side note. Page 192. Page 192. Rule of thumb says the same thing as we talked earlier about the angles of the right mainstem and left mainstem. Okay, any questions so far? No? We're good? All right. You guys, I'm sure, are familiar with mucociliary escalator, and if you're not, go to page 196. Page 196 will tell you what's going on in there. Let's go to page 194. I want to tell you something that you're always going to face and you're always going to deal with it, so make sure you know that few lines is there. You're always going to deal with that. And sometimes it becomes really annoying because they keep talking about it and we have to just whether get by and just let it go or whatever we have to do. So let's get to it right now. Page 194, right column, towards the end of the first line, it says, mast cells are 194, right column, towards the end of the first line. It says mast cells are. Make sure you highlight it to the end of that sentence. And then right at the end of the sentence, it starts with histamines are. You want to highlight it all the way to the end of the sentence or end of the paragraph. So what does it tell you? It tells us what is mast cells in our body. It tells us what does histamine do. Is that going to help us to understand pharmacology better? Absolutely. Is that going to help us what to do at what level? Because we have a drug, you guys know better than I, that we call, what do we call that mast cell stabilizer? Say that again? Chromium sodium, thank you. That's a mast cell stabilizer. So what it does to mast cell, it tells the mast cell, don't get upset. You don't need to become destabilized, stay stabilized. I'm here to help you out. That's what Intel does. So that's your medication you need to know. That's what it does. And then histamine. A lot of us take antihistamine medication when we have allergy and all that. That's what it refers to. So be sure to know it. That's what we're talking about. And then you can go to page 198. 198, what I want you to know, when you're looking at that figure A-50, conducting zone, I want you to write down delta space. Conducting zone, VD, you want to write down VD, delta space volume, right where it says conducting zone in yellow. So conducting zone, you do not have any gas exchange taking place. As a result is delta space. You want to write down 1/3 of a tidal volume. Delta space or VD equals 1/3 of tidal volume. So VD equals 1/3 of tidal volume. There is no gas exchange. That's conducting zone. It doesn't matter. Those of you who are going to the sputum bowl, you can remember numbers, the zones, but my focus more is on understanding what are we talking about. And then respiratory zone. Respiratory zone, we are talking about that VA, or alveolar volume, that's 2/3 of tidal volume. So every breath you're taking right now, as we talk, every breath you're taking, 1/3 of it is a waste. 1/3 of every your breath is not really doing anything. That's just a delta space is there. Just because our structure needs to have some volume of the air in there. The other 2/3 are going to do the actual gas exchange. Okay, any questions so far? No? Okay, blood gas barrier, you guys understand. Anybody has a question about what is a C membrane? Okay, if in case you don't know, you want to look at page 198, right column, last paragraph, under the heading it says blood gas barrier. Please be sure to study that all the way through. It's a couple of, we're talking about like a couple of paragraphs. Be sure to know it because you will deal with this a lot and a lot and a lot. Blood gas barrier, you need to know that as O2, this is O2 inside the alveoli, big A. As the O2 comes in, it has to pass through alveoli. And then it has to pass through interstitial space. And then it has to pass through the capillary epithelium. This is capillary. And then it has to go through plasma. And then it has to go through red blood cell. And then it has to go and get combined with, what do we have on our red blood cell? We have hemoglobin. Then it has to get combined with hemoglobin. Now, a question I have is, how many oxygen can we carry with one hemoglobin? 4. So be sure to know that part also. How much? What's the weight of it? What's the weight of it? What do we do when we do calculation for arterial oxygen content? We do PaO2 times, correct? And then we have another portion, which is hemoglobin times SaO2. Am I right? What is this then? What is 1.34? It's the weight. It's how much weight that the hemoglobin can carry. That's what we're talking about. And that's what it means when you can carry how much, how many, how much pressure. These are all different numbers and different figures and different units of measurement associated with that. Any questions so far? No? Okay. All right. Something fun you want to know, page 202, rule of thumb. Those of you who are going for a sputum bowl, you want to know it. If you care to know, and those of you who don't go to sputum bowl, it still is fun to know it. It's good to know it. Do you need a 5 minute break, or we should go to chapter 9? We need a little break? Okay. Let's stretch our legs and all that? Okay, let's do that. Let's do that.